I try to stick to the time, which I think is almost half an hour, and we spend a few minutes for technical reasons. The I will talk about some the topic which is currently in use in everyday practice, which is a surfactant. So what we know about surfactant, I will take you through the history of it and what is the future direction. Next, please. I, I understand you. We all know, as neonatologists, even a pediatrician, they know what is surfactant, which is a phospholipid. So it's a mix of lipids and proteins that produced by type 2 alveolar cells. And it is produced, if you remember, actually from your embryology, that is the stages of the development of the lung. At one stage, which is towards the end of the second trimester, nearly 24 weeks or so, there will be surfactant will be produced. Then, if people look at the amniotic fluid, there is maybe picked up in the amniotic fluid by 32 weeks, and will be abundant surfactant in the lung by 35 weeks. And we all know that is a surface tension lowering substance at the air-liquid interface. The composition of it, which we, not only the phospholipids, which is the majority, which is 90% of all the surfactant, but it's more important is proteins. And we have 10% of the composition, as I said, is the protein. Half of it is plasma protein, and half of it are the surface protein A, B, C, and D, and other proteins. But these are the main things, A, B, C, and D, because we are going to talk about the direction of the new surfactant and how it's going to be manufactured. And the A and D, which are responsible for the innate immunity within the alveoli, within the lung. And also, there are some data on D that has a role in the negative feedback of surfactant synthesis. P and C, which are hydrophobic, that are important for the spread of the surfactant equally and uniformly in the lung. Next, please. So the story of surfactant since it started is fascinating, in fact. So it's dated back to the 1929 by Neagard suggested that this is the first time someone talks about the surface tension as a force counteracting the first breath. And he pointed out there is a need for every newborn that the breath and the early breath to be investigated further. Next, please. But it always takes time for people actually to tune to any idea. And almost 20 years later, there is another Grunwald have shown that there is a surface active substance produced that reduces the pressure needed for aeration of the lung. Next, please. In 1950s, there are studies from different parts of the world. Actually, the researcher investigators didn't work together, but they studied the effect of nerve gases on the lung. And interestingly, the three of them have shown that there are bubbles covered by substance from the lining layer of the lung that lead to the understanding later on to the role of surfactant. Next, please. So this slide will show that happened from 1929, 47, and the three from England and Canada and USA who studied the effect of nerve gas on the lung. This led to the more studies on surfactant and its function. Next, please. in 1959, a very famous pediatrician, Mary Avery, I think all neonatologists come across her name, that has described hyaline membrane disease and also its association with the presence of deficiency or late appearance of substance that is in normal individuals makes the internal surface capable of attaining a low surface tension. And when the lung volume is decreased, so it's capable of decreased surface tension when the lung is decreased in size. And interesting, I met Mary Avery doing my training in Sydney. That is in 1995, and she was very knowledgeable. She passed away, I think, 2011. Next, please. This her study actually was amazing. Actually, study which opened the gate for understanding of the role of the surfactant as a surface tension lowering substance in the development of RDS, or that we called before the hyaline membrane disease. And this was in 1959, and that is showed that this is the surface tension versus the weight of infants in grams, and how the surface tension was high on those who died. Next, please. It is always the research and is the guided and supported and funded by politicians. And that's exactly what happened in Surfactant. The same story as is happening now when the Trump has helped, I understand, that put a lot of money into the development of the new COVID vaccine. It's and other politicians across Europe as well, and Australia and Canada. So here in 1963, after the President Kennedy and his wife lost their child, who was born at 35 weeks after a placental abruption. That is the New York Times that noted that there is no treatment, and since then that there was a lot of money invested in research into surfactant synthesis. Next, please. So within a year, trials started, and the first trial was a synthetic surfactant. That result was published in 1964-67, and this is the first surfactant to be used, which is the common part of the phospholipid, which is dibalmethyl phosphatidylcholine, that was used as a nebulizer, which when we take you further into the end of the journey or the recent journey, and you'll find this is now we are moving back to nebulized surfactant if we can. Next, please. This is a very important actually year in 1972, because actually the two obstetricians from Auckland, New Zealand, Graham Liggins and Howe, that they found that the importance of antenatal or maternal steroid to decrease the severity and rate of the RDS. Next, please. These are the two. Interestingly, it took 20 years for the obstetrician to apply this in practice. So not until the 90s, the antenatal steroid has been used, and still it is not the compliance of the obstetrician giving it to preterm delivery is still not 100%. And in UK, actually, I was looking at our data. It is never 100%. It could be 80 to 90%, which is these babies when born preterm missed the opportunity. That is because, as you know, as I just mentioned, this antenatal steroid is not not only good for the maturity of the lung and surfactant, is also for the effect of the exogenous surfactant on the lung and mortality and chronic lung disease. Next, please. So this is from here, it will be some surfactant have been produced that start to work. In 1980, this is Fujiwara, the Japanese one who worked in States, used the first natural surfactant of bovine derived called surfactant TA, and that treated 10 preterms, and the result was published in Lancet. Next, please. And that is just 10 babies, and they found there's improvement of after using the modified natural surfactant. This was in 1980. 10 babies were treated, 30 weeker, more than 1,500 grams. 2 of them have died, but the rest have responded to treatment. Next, please. Then Colin Morley, I think many of the neonatologists, they come across the name. He's a famous name and was actually famous in nutrition, which has heard Dr. Sana was talking about nutrition, and this he is very renowned of nutrition and who spent all his time in Cambridge, but moved to Children's Hospital in Melbourne, and I worked with him for some time in Melbourne. So he showed that neonatal mortality in 4 studies, 2 from Cambridge, 1 from Belfast, 1 Nottingham, in surfactant-treated preterm infants had lower mortality compared to the control in this all 4 trials. So surfactant can decrease mortality in preterm baby because it prevents respiratory failure. Next, please. So these are the 4 studies, and all of them have pointed to surfactant prophylaxis study. All showed there is mortality in babies who are born between 25 and 29 weeks. Next, please. So in November 84, in Sweden, there are the studies which are comparing the surfactant from Belfast. Henry Halliday was still alive, and he is still doing a lot of work. And CureSurf, which is the Volcain surfactant, the trade name is CureSurf. Also, they have shown that is the one from the Stockholm is working better, in fact, in treating RDS. Next, please. And this is I'm not sure whether CureSurf is in use in Egypt, because this is we use it here actually, and it is the drug of choice, in fact, that we use all the time for rescue and for the prophylaxis. And so it is a CureSurf, which is after the names of the 2 scientists who invented it. That's why it's CureSurf. Interesting. So I don't think the people are remembering the name of the inventors while they're using a CureSurf. Next, please. Of course, so we come across baby with severe RDS, and you can see before and after the surfactant and how the lung, the inflation is getting is better. Next, please. So since then, there has been clinical trials using different surfactant. The one is protein-free synthetic surfactant. Perhaps some of you who are as old as me that have come across the use of ExoSurf by Wellcome I remember that I was during some training. This was 1991 in John Radcliffe Hospital in Oxford. We use it. That is as part of Osiris trial. And this is one of the biggest trial in history. More than 6,000 babies were involved in this trial using the Exosurf, which is the alcohol-based surfactant. And that is the Lancet that published the result in 5th of December 1992. Then the next one was the natural surfactant, either of the bovine we call Surfactant, or of porcine nature, which, as I said, is a reserve. Then the new synthetic surfactant, which we will talk about later, that it contains protein analogs. And this is difficult sometimes to remember. It is CHF 5633 that has been recently studied. Next, please. So what we think the future holds. There may be new generation of synthetic surfactant with protein analog. Could be the way we give surfactant, because the way we give now, or not now, for many years, by putting a tube down and give surfactant directly in the airway, which is it is not stress-free with many complications, and particularly it needs a special technique and a special skill. And we know that repeated intubation more than 3 or 4 can cause mortality or increasing comorbidity. Or we can nebulize or atomize a surfactant directly to the lung, as was the first attempt in, as I mentioned before. Next, please. Next, please. So when we look at the European guidelines, which is in 2016, about the consensus of the management of respiratory distress, so they recommend, and what we are doing in practice, all babies with RDS should be given natural surfactant preparation when needed. So natural surfactant. Next, please. And the superior efficacy of the animal, which is natural surfactant, over synthetic surfactant was due to important things, is protein B and C. That is the main thing, the protein B and C. Next, please. And if we compare the animal-derived surfactant versus protein-free synthetic surfactant for prevention and treatment of RDS, the Cochrane, so the mortality and the pneumothorax. So the conclusion is animal-derived surfactant extract seem to be more desirable choice because it decreases the pneumothorax by third and 10% almost of the reduced mortality. So it is preferable. Next, please. So the question, what makes synthetic why synthetic surfactant could be the way forward? We shouldn't depend on animal sources. There is a possibility of virus transmission. In Egypt and some other countries, the religious and ethical consideration, and in some part of this country, in UK, where it is multicultural society with a lot of ethnic Asian minorities, the parents got the option of the bovine surfactant or porcine surfactant, and that has been an ethical issue. Less batch-to-batch viability, optimizing pharmaceutical quality of the product. It could be more effective or cost effective. That is so that triggers the reason why synthetic surfactant could be the way forward. Next, please. Interestingly, actually, in 2012, there has been lucinactant was a synthetic surfactant with peptide, but it was, you see, viscous, need warming bath prior to use, and has gotten approval for use license in 2012, but has never been used, and production ceased in 2015. Next, please. So if we compare the protein-containing synthetic surfactant versus animal-derived surfactant extract for the prevention, you will find there's no difference. This means is if we have a synthetic surfactant with protein B and C, that we're going to show in a minute, it is comparable and not inferior for the prevention and treatment of respiratory distress syndrome compared to natural surfactant. Next, please. And if we have a surfactant that contains B and C surfactant protein, is enough, or we have only one of them, and in this one, the total volume will be better with the same, which means the compliance is better by having both of them. Next, please. This is the first fully synthetic surfactant preparation, and that contains both surfactant protein B and C, and was tested both in vivo and vitro for surface tension lowering properties, and has gone through phase 1 and phase 2. The feasibility trial about toxicity and systemic absorption, immunogenicity, and efficacy that I'll show in the next one. Next one. Next, please. This is the product, which contain B analog of 0.2% and C analog 1.5%, and the majority, 98% of phospholipids, majority of it dipalmitinoid phosphatidyl choline. Next, please. And this is the first one clinical trial, and it was a multi-center trial that is completed, and the main objective was safety and tolerability, and the secondary efficacy and systemic exposure and immunogenicity. Next, please. And just I wouldn't go through this because actually this is the recruitment criteria, 27 to 34 weeker, less than 48, and this is criteria actually to include in the study. Next, please. So we were part of the study in UK, and friends from Edinburgh, Ben Stenson and colleagues have been part of it. Germany and Czech Republic also was involved in the study. Next, please. Next, please. And this is the finding. It was very promising. That is there has been some improvement in oxygen within 30 minutes in 39 infants in almost 98%, and there were one adverse reaction, an episode of transient obstruction of the tube, but apart from that, the 2 deaths was not related to the surfactant. Next, please. The interpretation of its use was that it's clinically effective, and both doses were whether 80 or 100 were effective and well tolerated. Next, please. What about long-term outcome? Developmental outcome at 18 months was comparable to the peers as well, to the controls. Next, please. This was the number was 40, and they were followed up for 2 months, and number 18. So there was a dropout of some of the babies, in fact, that is half of them. Next, please. So it went to phase 2 complete trial, and that was all this, all the center were in state. Unfortunately, we were not part of any of it. And they recruited between 24 and 29. They got very strict criteria which baby will be given the surfactant. And there was head-to-head comparison between this surfactant, to Curacao. That is, I understand that this study has been completed in 2018 or 19, but actually we haven't got the result yet. So it is not yet available for use. Next, please. So what is the way forward apart from surfactant? The treatment of RDS is recruit the lung, so prevent alveolar collapse, which is, and keep the functional residual capacity. And that is the preferred management now, is to use the primary CPAP with the use of rescue surfactant for infants with increasing oxygen requirement. So it's a possibility of using only CPAP is, if possible, is better than the intubation and surfactant. Next, please. So to reduce the need of mechanical ventilation, but still some babies will need surfactant because of RDS surfactant deficiency for immature lung, is some less invasive techniques have been developed. Some of this technique, we call it LISA, or less invasive, the surfactant administration. In fact, this has been one of my colleagues, who was a professor in Bonn, and they have been using it in Germany for ages, in fact. So it is not a new thing. It has been going on for some time in some part of Europe. Next, please. So there has been some studies that looking at this technique and the risk of, and the reduction of the risk of mechanical ventilation within 3 days, and the development of bronchopulmonary dysplasia 3 days, 36 weeks, compared to a strategy. And there has been reduction in both. And also, if we compare it to the use of Ensure, which you intubate and give surfactant and extubate, that is, the meta-analysis of it have shown that it is less need for mechanical ventilation and better outcome, which is a composite outcome of the death of bronchopulmonary dysplasia at 36 weeks. So LISA works. Next, please. And this is the latest European consensus guidelines suggested treating infant less than 26-week gestation when the oxygen requirement increase above 30 with surfactant, and if more than 26 weeks and oxygen requirement of greater than 40 with surfactant. Next, please. And this is our local guidelines in the clinical managed network in Scotland, that we do LISA, less invasive surfactant administration in infants less than 32 weeks when the oxygen requirement is 30 weeks, 30% or more. It usually in the first hour, but can extend it to the 72 hours, but usually is in the first hour. If more than 32 weeks and the oxygen requirement is 40 or more, so we use this technique. I'm not sure about this because there are the conflicting data on it. Some of my colleagues are still using this technique in more than 30 weeks. I'm not sure whether we can intubate because they are at the comorbidity and the tolerance of intubation is this baby can cope with, and there is less likely of the development of the bronchopulmonary dysplasia. So they can be tolerated well, in fact. Next, please. This is how we do it. I won't go through the step from the caffeine, how we do it. Actually, I'm leaving this presentation, so whoever wants actually to go through it and just update yourself and to the current approach to this technique, feel free. If you want to give me to drop an email asking for the technique and the video, I'm happy to help. Next, please. The only thing that has been discussed is about sedation. Should we give sedation? And sedation could affect respiratory. It can cause respiratory compromise and no RCT and the use of medication. And we have different opinion here, even here among ourselves. Should we give? I myself, I may go for fentanyl, nasal fentanyl or buccal fentanyl. Some may give it as IV. With the problem of it may cause the chest rigidity. So this has not been sorted out whether to give sedation or not. So it is left for the operator. And also atropine as well, if you are expecting the bradycardia during the operation. Next, please. And this is actually this is the step-by-step approach to the LISA procedure. Next, please. The important thing is during this, the administration of the surfactant, the baby should be spontaneous breathing on CPAP. As I said, CPAP is the treatment. It is the grunt. So baby, the CPAP has to be continued throughout all the procedure. Then you give surfactant. Whether to give another dose or not, this again another stuff that is to be considered. Next, please. This is how we administer the surfactant for any procedure. In UK now there is what we call bulls. So people have to have debrief and know exactly the equipments are enough, the patient is ready, and the team is available for any procedure. Now, if you go to theater for resuscitation, this what will happen is debrief or huddle, so you have a boost. And this is tick box exercise. So, which is extremely important because actually you don't, in a hurry, you want to find something which is not there. So you need to be prepared now, rather than sorry. So this is a very important thing, I think, that is happening here now for many years now. So you need to tick all these boxes before you start the procedure. Next, please. Next, please. For every procedure, especially any new innovation, you need to collect data and audit the data. These are how you collect the data for every procedure, so you learn from mistakes. So that's exactly what we do. So for every procedure, so you collect the data, and by collating this data, you come to some conclusion and improvement or quality improvement projects. Next, please. So I will, because I took too much time, so I want to be to be as quick as possible. So, this is the only way you're giving surfactant apart from the tube? Yes, not the only way, because actually we said about the LISA type. Then we have surfactant through the laryngeal mask. Airway. Next, please. Yes, there is administration of rescue surfactant by the laryngeal mask airway. And there are the reports and some data on it using it, even a small baby. And one actually was in the Journal Pediatrics in 2018. We have some guidance on it actually in the managed clinical network in Scotland. So we have been using it, but there are some criteria for the babies or the candidates that we can use it on. Next, please. So this is 1999. Then people have tried actually 800-gram neonates with the laryngeal mask, and it seems that may work, but it is the concept of using the mask, which is easy to apply. Next, please. So there are few literature support the use of this technique in babies more than 1,200 grams, and this what we use in our guidelines here in Scotland. It is that we can use a surfactant by this technique using laryngeal mask in babies who are more than 28 weeks and more than 1,200 grams. In fact, we tend to be more cautious with this age group, and we tend to start LISA rather than laryngeal mask. Next, please. These are the equipments we use. Eye gel as a laryngeal mask. I'm not sure that whether laryngeal mask is available in Egypt or not. It's easy to administer. Next, please. And this is the laryngeal mask here, which is the eye gel. And this is the size one, which is meant to be for babies who are 2 to 5 kilos. This is the smallest one we have. Next, please. So this is how we give it. Again, if we have videos all of this actually, how to administer the surfactant using LISA or using laryngeal mask. And if anyone is interested, I can email these videos and the step-by-step technique of administering the surfactant. Next, please. And this is the preparation again. Next. Next, please. Next, please. And as I said, after everything, we collect the data and we audit it, and from that we can assess our techniques and whether successful or not, and can improve on the technique and the outcomes. Next, please. The current research, people actually from Australia, the Peter Darglib, I worked with him actually in Melbourne. He's very interested in respiratory, has done a lot of work on high frequency, and also Peter Davis from Melbourne. They have started a study, not started, actually it's now, has been a couple of years now, Optimist trial, which is in evaluation of minimally invasive surfactant therapy in preterm infants 25 to 28. The Australia were the first to use or to apply what we call MIST trial, which is minimally invasive using the special angiocath. That is how to register with for this research. But they are almost at the end of it. Next, please. So in general, this is the way forward of the surfactant. The synthetic surfactant with peptide, and mainly surfactant protein B and C. Second, less invasive, the installation of the surfactant. And I think the nebulized surfactant is the way forward. Thank you very much for your time. And this is my email. If you have any questions, need any guidelines, I'm happy to help. Thank you very much.